All right, guys, we might get underway. So thanks everyone for coming, and good evening, everyone. So before we begin, I'd like to acknowledge the traditional owners of the lands on which we meet today, the Wurundjeri people of the Kulin Nation, and pay my respects to the elders past, present, and emerging. So my name is Victor, and on behalf of the Australian Student Society of Haematology, it gives me great delight to welcome you all to the first ASSH seminar for 2020. So ASSH was not that ASSH. So ASSH was founded in 2019 as a professional society with a mission to connect, educate, and inspire university students who are interested in blood disorders. ASSH now has a membership base of over 200 students studying a range of courses at multiple universities across the state. Through our events, it is our hope to be able to demonstrate to students that far from being an esoteric discipline littered with impenetrable jargon, that all sounds suspiciously the same, that medical school often makes it out to be, haematology is an infinitely fascinating specialty that permeates almost the entire spectrum of clinical specialties, from general practice to critical care. So tonight, it is our privilege to be able to invite Professor Huyen Tran to share with us his expertise on venous thromboembolism, a common and frequently recurring condition that affects at least 17,000 Australians each year. Professor Huyen Tran completed his medical degree at Monash University and his dual fellowships in clinical and laboratory haematology in Melbourne, Australia. He spent 2 years at McMaster University in Ontario, Canada, with the Clinical Trials Group to further research in thrombotic disorders before returning to Australia to complete his Master of Clinical Epidemiology and join the Haematology Consortium as a senior haematologist. He is currently director of the largest haemophilia treatment centre in Australia and head of Hemostasis and Thrombosis Unit at the Alfred Hospital, chair of the Australian Haemophilia Centres Directors Organisation, and Clinical Trials Group of the Thrombosis and Hemostasis Society of Australia and New Zealand. He's past president of the society and formerly head of laboratory haematology at Monash Health. His focus is on clinical research in haematology with particular interests in thrombotic, bleeding, and platelet disorders. He has been the lead investigator for many clinical trials evaluating novel coagulating factor drugs, new anticoagulants, and thrombopoietin agonists at his institution over the last 20 years, and contributes to many health advisory boards in these fields. He has authored several well-received publications in peer-reviewed journals. He's interested in standardizing practice of care and has led several national guidelines in thrombotic disorders. Last year, Professor Tran led the development of Australia's first guidelines for diagnosis and management of VTE. So suffice it to say, there's no one more well-placed to deliver this seminar. Please join me in welcoming Professor Tran.
Thanks, Victor. Seriously, I need to cut that back. You asked for 200 words. That really sounds more than 200 words to me. So I'm really glad that some of you are here and not out there racing to clear the supermarket shelves with the toilet paper. Much of my career has been dedicated to venous thrombotic disease, and the other half of my brain is bleeding disorders. Okay, so today we're going to focus on the thrombotic disease. Let's get to it. So it's not very sexy disease. It's not very emotive, but I'd have to say to you that it's a very common disorder. It's almost ubiquitous. Okay, so you can see here the annual incidence of VTE is about 1 to 2,000 per year, and the incidence increases with age. So I would guess that all of you guys sitting here in this room will be younger than 30 years of age. Your baseline risk of having an episode of venous thrombosis is in the vicinity of 1 in 10,000. Okay, and it'll be no more than 1 in 5,000. But around the age of 40, the curve starts to kick up, and by the time you're 80, the risk is 1 in 100. Okay, and you can see there the annual fatal autopsy detected pulmonary embolism is about 1 in 5 in 10,000. And it's really the leading cause of preventable death in hospital, and I would say worldwide. In Europe, there's about 500,000 people affected with VTE per year, okay? And that's more than motor vehicle accidents, breast cancer, and HIV combined. Now, once you have VTE, it's really, with the exception of you getting a DVT or PE because you've had a massive car accident and you visit the trauma centre either here at the Royal Melbourne or at the Alfred Hospital, or you've had one because you've had a massive operation that lasted several hours, it's really a chronic disease. And so you have a 30% risk of recurrence at the 5-year mark. And our Scandinavian colleague has shown that the risk may be 50% out 10 years. Okay, so it's really a chronic disorder. I'm sorry about the small slides. I was a bit bored doing my slides, shuffling them. But probably the one that I want to highlight to you, apart from what I've said, is this, the line in the middle. And the line in black shows you that 5,000 people die from VTE per year. Okay. And hence last year, the federal government, together with the Society of Thrombosis that I previously chaired, has launched national standards for the prevention of venous thrombosis in every hospital. Because across the board, numerically, the moment you step into a tertiary hospital, you have a 1% risk of leaving the hospital with an episode of VTE. So thromboprophylaxis, although it sounds really boring, it's actually quite important. Okay. The circle on the right really just shows you the economic cost of having VTE, and this is really old data now going back to about 10 years. There's direct and indirect costs, but we estimate it's about $17 to $18 billion of treating all these patients per year. Okay, some of which you as a patient, if you suffered an episode, have to wear. So what are the impact of VTE, venous thromboembolism? So the two common ones I want to focus on are really PE or pulmonary embolism, the other being DVT or deep vein thrombosis. The consequences of these are there's a chance of risk of death. So the 30-day mortality rate they have not managed properly is about 15 to 30%. And the risk of pulmonary hypertension, so that is the consequence of blockage of the circulation essentially, is probably somewhere around 1 to 4% at 2 years. I think the 4% is an old estimate. My current PhD is looking back at the data and we probably think it's 1% now because we've got much better treatment, much better system in place. Now with deep vein thrombosis, you'll hear it all the time, prevention, you get on the aeroplane, and I kind of snigger, and we'll come back to talk about the risks for DVT and PE and air travel we may touch on. But one of the consequences of DVT, apart from embolism, fracturing off, going to the lungs and giving you a PE, is something called post-thrombotic syndrome, short acronym PTS. Okay, and the reason for that is clots almost always begin where the valves are, okay? And you don't have a laminar flow anymore, and clots that start there and it gets bigger. And when we give treatment, and we'll come back to this later, it is an anticoagulant, okay? So by that we mean we rebalance hemostasis so that we prevent further clots being formed. We don't give thrombolysis unless there is a life-threatening or limb-threatening situation. And so your body, through a process of fibrinolysis, and I hope you've had the coagulation lecture, breaks down the clot. And so if your body is not able to break down the clot in a timely manner, you're going to have valvular incompetence, you're going to have little cell layover, and then you get this syndrome of post-thrombotic syndrome. It's really characterized by, swollen leg, hyperpigmentation, ache, and in about 5 to 10%, they get venous ulcers like that. And it's pretty nasty, it's pretty difficult to heal. So they're the consequences of PE and DVT. I'm sure you heard of Virchow's triad, yeah? Please say yes, okay? So Virchow was actually a very eccentric and smart med student like you. And he coined the triad for the risk factors of venous thrombosis back in 1856. So we've known about the risk for hundreds of years. And you know, like all the case, if you're eccentric and smart and you push the boundary, you get persecuted. You got chucked out of med school, just in case you weren't aware. And eventually he got back in. And the other famous thing about this man is that he created the autopsy platform, which we pretty much still use to this day and age, okay? So Virchow's triad is really three things. One is injury to the blood vessel, because if you injure the blood vessel, there's a hole in the blood vessel, you stimulate coagulation, okay? Now, immobility is a really interesting phenomenon, okay? In humans as well, there's a clear clinical association. If you sit there for 24 hours, 72 hours, or if you have surgery, go home and you get endone, you know, and you're bombed out, you know, there is an increased risk of thrombosis. But yet, in animal model, if you take blood and you put it in a tube and you leave it there, that doesn't clot. So there are other factors associated. Now, the last thing is thrombophilia, the constituents within the blood, okay? Because we're always forming blood clots and then we break them up. And there's various hereditary entities. And I hope that you've heard of things like deficiency in natural anticoagulant, antithrombin deficiency, protein C and S deficiency, and more commonly factor V and prothrombin gene mutation, which by the way is associated with very low risk of recurrence, which I'll come back to. And yet some people put a lot of weight on it. And I've spent part of my life trying to dismantle that myth. Amongst the acquired conditions in terms of thrombophilia, the most important one that I want you to be aware of is something called antiphospholipid syndrome. Okay, that is an acquired phenomenon. It can exist on its own or it can be part of an autoimmune disease called SLE, systemic lupus erythematosus. But in my world, we see this in isolation, okay? And it's really characterized by laboratory parameters, but they get venous thrombosis and their risk of recurrence is quite high. And they're also at risk of arterial disease. Cancer, very obvious. You got cancer and you get clot, your mortality is not looking great. There's an issue about hormonal estrogen and so on, okay? And there's pregnancy as well. Trivial pursuit question. Does anyone want to tell me why World Thrombosis Day is on October 13th?
Because there's 13 steps in the formation.
Oh, no, wow, no. How much time have we got? One more guess? In the context of what we've just been talking about. No, Wolfram was discovered in the 1940s. It stands for Wisconsin Alumni Research Foundation, ARIN. Okay. One more guess, last one. Come on, it's the end of the day. You got to keep you entertained. It's Virchow's birthday. Okay. So every year, October 13th, if you know family members who's had clots, supported, and I'm not breaking confidentiality. Have you guys heard of Dr. Feelgood? She may be a bit old for you. She was Dr. Sex, Dr. Feelgood. How many of you guys were born in the 2000s, by the way? Any of you? Oh la la, I'm getting old now. Anyway, she had a big radio station in the 1990s. She's an ambassador for us now, and this is public knowledge. So I'm not breaking confidentiality because she's been in, you know, the Sun and the Age and all those things, and I have her permission. But she nearly died of a massive pulmonary embolism. Okay, and you know what saved her? The iWatch. She called the ambulance on her iWatch as she was collapsing. There you go. Let's talk a bit about risk factors, okay? And I think that you just need to get clear in your head what are the strong risk factors, and then that's the rest, okay? I think that through medicine, we try to complicate things and to make us look really smart, but really at the end of the day, just keep it simple. Okay, so let's talk about the strong risk factors to the right. Okay, now I don't know why I highlight family history, because I think it was some new data a few years ago and I got bored. But if you've got 2 first-degree relatives, you guys know what first-degree relative means? Yeah? Okay, so mum and dad, brothers and sisters, you've got a really high risk of having a clot yourself, okay? Whether or not you have an identifiable thrombophilic marker. Orthopedic surgery. I've just been asked to order our own orthopedic because they had this clustering in the last 30 days. They've had 9 episodes of pulmonary embolism despite appropriate thromboprophylaxis, okay? Major trauma, again, some of you guys I've heard spent time over at the RMH, and Alfred is a huge trauma center. That's half my work there, okay? And spinal cord injury, obviously, because you're lying there, you're immobilized, okay? And then there's the rest, okay? Now, I get a lot of students coming to my clinic and they blah, 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 and they get lost in numbers and knowledge. But the first thing you have to remember, you're in med school to become a clinician. So a clinician means you've got to talk to your patient, unless you want to be a pathologist or a radiologist later on in your life, okay? You've got to talk to your patient. So taking the history is really important. And I bring that up in particular to that point about immobility and how you classify immobilization, okay? So don't take patients' word on face value. I was immobilized, but you know, if you're sitting down study for an hour and you're getting up and doing your dance or whatever, that's not really immobility. But at the other extreme, we get patients that are upset to you coming home on, you know, severe pain relief medication, and they're bombed out for 18 hours of the day for about 3 consecutive, and then they get a clot. So that's immobility, okay? Air travel, my friend, is not a high risk factor, okay? Contrary to popular belief, the reason why the airlines espouse this is because they don't want any liability. So when we look at the rates, it's probably 1 episode every 5,000 to 6,000 episodes of long haul flights. So when you hear this thing flying to Melbourne, to Sydney, or I go to Canberra and meet with a politician, it's not a risk, okay? But they espouse these things. So, and by the way, if you think you have a low risk in business class, that's not true either. The risk is the same. Now, the diagnosis of DVT and P is important. Now, obviously, the symptoms for both conditions are non-specific, okay? So, and I think this is a really nice table that we've created over the years. It shows you that you come in with pleuritic chest pain, hemoptysis, you got, and all of those things I've outlined there. That alone, I can say he's got a PE, you can say he doesn't have a PE. Both of those could be right. So symptoms alone in isolation doesn't cut it, okay? So then what we then need to do over the years is what we call prediction scores, okay? So you change, you're trying to create a prediction score so that you know, don't end up investigating everyone, and you can justifiably send them home when you are confident enough. Now, hopefully you've seen, okay, probably the most commonly used and well-validated one is the Wells prediction score. I'm probably biased because I worked with Phil Wells last decade, and it's a really good score. The other one is the Geneva score, and that was done by our Genevan colleague. It's a bit different, but it's a little bit more heart rate and so on. And then the last one, if you guys become emergency physicians, they love this one. It's called the PE rule out, okay? And you'll have copies of my slides, and there's the scores there, okay? And then you add them up, and it really creates whether yes, likely, or no, unlikely. And then that sort of guides you whether you can say, work out the probability of their having clots. Now, this is to say to you that regardless of the pretest probability, you do it and it's important. If it's high pretest probability, they need a scan, full stop, okay? Even if it's low probability, and I'm using the example of DVT here, you've still got a 5% risk of having a DVT. You say to the patient, hey, you don't have a DVT, you can go home. So over the next 90 days, they're going to come back with a DVT and they can break off and embolize and have a PE and potentially die. So is that good enough? I don't think so, okay? So what used to happen was that, let's get everybody a scan, okay? If you suspect a PE, you get a CT polyangiogram now, or in the olden days, you're a female and there's risks of radiation to the breast, you get a ventilation perfusion lung scan, okay? But the problem, if you did that, you're going to end up doing a lot of scans. And you're going to clog up the radiology department. They'll hate you. And also, it's going to huge cost to the community. We're talking about sustainability of healthcare. And this is a very good example. So I've looked back at our data very recently at a different place that I have something to do with. You can see there, 300 plus patients presented with suspected PE over 12 months. Okay, more than half was considered low probability, went to have a VQ scan, and you had 0.6% having a PE. So that's a hell of a scan for a single positive outcome. Okay, so obviously that system's not working. So just while we're on the imaging, so if you're looking for DVT, ultrasound, you're all aware of ultrasound, okay? Non-invasive, very good test, particularly for diagnosing and ruling out proximal DVT. In Australia, distal DVT, I don't really have time to go into the depth of 50% of our distal DVT, but you probably don't need to treat them all, okay? So ultrasound is the go-to. A bit of anatomy, please. I'm trying to change the culture. I still see my new advanced trainee calling clots above the knee DVT or below knee DVT. As a purist, I don't like it because we're talking about venous anatomy. We're not talking about surface anatomy, okay? So the correct term, if you look at guidelines, we use the term proximal DVT or distal DVT, okay? Proximal, by definition, that is anything that involves the popliteal vein and its trifurcation or proximally, okay? And that's one of the most important things I want you to take out of here. If you have a proximal clot that involves they need treatment for 3 months at least, full stop, okay? If it's distal, let's call it infrapopliteal. There are 3 main veins, but let's call it infrapopliteal. If you've got distal DVT, if they've got a high risk of bleeding, you can afford not to treat them, do serial ultrasound, or if you do need to treat them because they're symptomatic and they're safe to do so, you can probably treat for 6 weeks. And we've just finished a study suggesting that's probably 2 weeks can do it as well. But definition, if you can just remember that. Let's skip through this. Now, lung imaging. So there's 2 modality, VQ scanning. The positive side, the good things about VQ scanning is less radiation, good for young women, less exposure to the breast, pregnant women. But the problem is that across the board, unless you're young and you don't have clean pulmonary, vasculature and so on, 60% of it is non-diagnostic. Okay, so that's why we went to the CTPA, okay, CT polyangiogram. It's really not that invasive, and really with the new multi-slicer scan, you can diagnose the PE quite easily with filling defects, and you can also see alternative explanation for the symptoms too if you rule it out. There are inefficiency, but really it's probably not up to think. And this is Bithens shielding for women if you worry about radiation to the breast. Okay. You guys have the D-dimer. Yeah? Okay, so the D-dimer is basically fibrinogen degradation product, and it's a marker of clot formation and breaking down. Okay. So how do you use the D-dimer is really what we need to talk about. Firstly, to say the D-dimer is non-specific. So meaning that if you've got a clot, it can be high, but it can also be high if you're pregnant, if you've got an infection, you've got cancer, inflammation, and there's also an age adjustment as well, which gets too complicated. Now, If it's negative in this context of a patient presenting with suspected DVT or PE, that's when it's useful, okay? But it needs to be combined with the pre-test probability of the clinical prediction score that you've used, okay? If it's positive, then it could be a clot or it could be something else, okay? So this is some work that we did together with Phil years ago now, you can see. Because we said before that you've got a low pretest probability, you still got a 5% chance of going home with a clot. That's not good enough. But if you combine it with a negative D-dimer, that risk is below 1%. Okay, now we're happy. Okay, you'll miss the majority. Now we're happy. We still say to the patient, you've got symptoms, come back. But I think that's safe enough, medical, legal, as I see you later. Okay, you don't need a scan. So the algorithm for patients presenting with suspected DVT is you do, for me, the Wells Clinical Prediction Score. If it's high, you go straight to the ultrasound. Simple, yeah? If it's low, less than 2 or less, you D-dimer. If it's negative, see you later. Go home, keep going to your lectures. If it's positive, then you need to have an ultrasound. Okay, so that's the algorithm. Now for PE, it's pretty similar as well. Okay, suspected PE, unlikely, do a D-dimer. If it's positive, scan. If it's negative, you go home. If it's highly likely, just get to the scan. Don't waste your time with the D-dimer, because in our hematology laboratory, you know, by the time they're in ED, take the blood, send it up to the lab, come back. They're going to be delayed of an hour or so. Okay, so you just get to do the scan and work it out. Let's talk about the treatment. So I've mentioned already that the mainstay of treatment of PE and DVT is anticoagulation. Okay, there will be some instances where patients have a massive one and they are hemodynamically unstable, and that's when we give them thrombolytic therapy. Okay, we don't do it all the time because A, it's unnecessary, and 2, there is a much higher risk of major bleeding. Okay, so you have to select the right patient. And then the second component is the duration of anticoagulation and sussing out the right patients in who should receive long-term anticoagulant therapy. And that's the crux of our clinic, our follow-up clinic. So I'm not expecting to know the dose, but I do hope that you have some ideas of what drugs we're using initially, okay? And let's break them into 2 groups, the old and the new, okay? Anyone want to tell me what the old are? Thank you very much. And so obviously the rest are the new, right? So what are the new? Apixaban, rivaroxaban, okay? What are they called collectively? I call them DOACs, okay? I was there when we created these drugs. They're not new anymore, they're not novel, and they're direct, so that's my little pet thing. I have joyous discussions with my colleagues all the time for those reasons. Now, why did we create these new drugs called DOAC, apixaban and rivaroxaban? And so I should mention dabigatran there. So dabigatran works differently. I'll come to the mechanism in a minute. Put dabigatran there to appease our New Zealand colleagues. It's just that in Australia, apixaban and rivaroxaban are funded on the PBS, okay, for VTE treatment, whereas dabigatran is not. Dabigatran is for AF only, okay? Whereas now New Zealand, they have a different system, so they have dabigatran. Okay, so we try to be inclusive with our friends. So this is the have you guys seen this? Okay, you need to know this. You need to know this because I still see students, final year students, resident interns, and even advanced trainee. I used to write the question in hematology for the specialist physician exams. You want to pass that hurdle, okay? And that was one of my pet things. Okay, and it was a very good discriminator whether you pass or you fail the specialist exam. So in a nutshell, thrombin at the bottom is the most important thing. It is central to the coagulation cascade. Okay, thrombin at the bottom. So you either block thrombin or you block the generation of thrombin. Because thrombin can positive feedback and act on platelets and activate other amplification clotting factors, which we won't talk about today. So the bigger tran at the bottom there is a thrombin inhibitor. Okay. To stick to the left as well, you can see that rivaroxaban and rivaroxaban, they are direct factor 10A inhibitor. So they block the factor 10A, therefore you cannot generate thrombin. Okay? Just different targets with the same effect. Warfarin, you can see there, they're non-specific. And obviously there's the target of warfarin. It used to be easy because we didn't have Netflix in my days. We just had TV channel. Do you remember what they are? What the targets are? 2, 7, 9, 10. Okay, so they're non-specific, so multi-target. Okay. So, and then to the right, they're the injectable, the heparin, and virtually all of them, with the exception of the pyridine at the bottom here, they're all antithrombin dependent. It's like the accelerator. If you don't have antithrombin, the heparin don't work as well. Okay. And the difference really is the mode of administration. So parenterally, unfractionated heparin is given by an infusion. We don't use that so much anymore, except in the intensive care setting or high-risk bleeding, because it's got a short half-life of under an hour, and if there's a problem, you just turn it off, okay, and it washes out. But controlling can be difficult. Low molecular weight heparin is a great drug, okay? The only problem with this drug is patients don't like it because they have to inject themselves. But at the end of the day, if you've got a concern, give them low molecular weight heparin, okay? It's the go-to drug. Fondaparinux, the rest don't worry about it. It's really research stuff. Now, to the left, let's go back. Warfarin, our old friend, as I said before, stands for Wisconsin Alumni Research Foundation. It was discovered in Wisconsin, obviously. This farmer saw his cows hemorrhaging to death, eating these certain clovers. And that's when they found the compound arin. But we actually didn't understand the mechanism of warfarin until the 1970s. It's a gamma carboxylase blocking the synthesis of 2,7,9,10. Okay, so it took that long, and many PhDs. Rivaroxaban and apixaban, as I say, the important parameters of those is that it's quick onset of action. Okay, so you take it, it's got a peak value effect within 1 to 2 hours, and by the same token, at the other end, if you stop it, it washes out your system within 24 hours because it has a half-life. And all of you young people sitting here of under 12 hours. Okay, and even the more aged individual, it's probably still around 12 hours. Okay. And rivaroxaban and apixaban in particular is very gentle on the kidney. Its elimination by the kidney is probably only about 1/3 at most. The bigger tran at the bottom, it's 80% renally excreted dependent. So you don't want to use it in aging people where their kidney function is a bit wobbly. Okay. And also the other common side effects of the big tran is actually dyspepsia, heartburn, about 12%. Okay. Now warfarin, it's a dying art. I belong to that era, so I can still manage warfarin pretty well, but I promise you, when you guys, by the time you're interns and residents, you're probably not going to see too much of warfarin. The only remaining indication of warfarin are if you've got a mechanical heart valve, okay, because that's been shown, well, it's been shown that the other drugs are no good for mechanical heart valves. Antiphospholipid syndrome, I told you about before, because when we did the randomized controlled trial, it was superior to all the other drugs. Okay, So triple positive antiphospholipid, they should still be on warfarin at this stage, and the rest. And the thing with warfarin, what's the half-life of warfarin? Anyone? You need to learn your anticoagulant. It's about 48 to 60 hours, okay? But as I said to you before, the anti-thrombotic effect of warfarin is that long, because that's how long it takes for you to block thrombin, okay? And that's why if you're using the old school low molecular weight heparin and warfarin, you need to start with low molecular weight heparin, and you give the warfarin at the same time, because there's warfarin slow to have its effect, and you need coverage for the patient initially, okay? And you keep the heparin going for 5 days minimum. And this is a great exam question. The question is why? Why do you need to keep the heparin going for 5 days? So in other words, if your INR is 2.3 at day 2 and 2.8 at day 3, do you stop the low molecular weight heparin? The answer is no, okay? Because you're really only had an effect on factor 7, and it's got a short half-life of about 8 to 12 hours, and that's what you see in the INR. You haven't really blocked the thrombin component, okay? So there's no need to be aggressive with warfarin at the time, and you need a minimum of 5 days of heparin, okay? Then when your INR is in the target range between 2 and 3, after 5 days, then you can stop the heparin, okay? If you're ever doing that, if you do that, your consultant will be very pleased with you. Whereas the other drug's easy, okay? And this is what I'm getting to. If you got DVT or PE these days, I find my job a bit boring now, because the fun of the research and this is gone. I spent 10, 15 years of my life working this out, okay? Because now if you get a clot, I just go, hey, do you want apixaban or you want rivaroxaban? Okay, I can't say which one is better than the other, because A, we don't have any comparative trial against one to the other, but although we're about to do an international trial for the COBRA, so looking at safety with the Canadians. So I won't break MRFF and HMRC coding, but that's the new study that we're going to look at the safety. But in effect, I can't say, I'll have to say to you, do you want apixaban or do you want rivaroxaban? Okay, because they work just as well. Or you can say, do you want low molecular weight heparin and warfarin? They have that right too, because warfarin in all our studies, because I don't have time to tell you all this stuff, is as good as those two drugs. Okay, but there's no study comparing rivaroxaban versus apixaban. Okay, and by the way, I don't have shares in any of these companies. Okay. So you can see there, you start them on a loading dose and then you cut them back. And there's many other studies that we've done as well that demonstrate that we can reduce the dose safely as secondary prevention because of that ongoing risk of recurrence. Okay. I think we've talked about this. So I'm ahead of myself. Okay. So if that's one useful slide you're going to go back look at before your exam, take a look at that, okay? And this is just a meta-analysis that a colleague of mine in Amsterdam did a few years ago, summarizing all the data, and it really looks at the net benefit of apixaban and rivaroxaban compared with warfarin, button K antagonist is warfarin, okay? So you can see for various endpoints there, major bleeding, blah, blah, blah. Okay. If I had a clot, apixaban or rivaroxaban, please. I might have rivaroxaban because it's once a day. There's a compliance after the loading. And for women, maybe apixaban because there's more signal to heavy menstrual loss with rivaroxaban and valproate. Okay. So these are the advantages. That'll be a good oral question in your OSCE station. You guys still have OSCE stations? Yeah? Yes? I can go. Let's talk about treatment of DVT. Tell me about the advantages of these new drugs. There you go. One dose, no dose adjustment, no monitoring. Okay, because in the olden days, warfarin, obviously because there's a lot of food and drug interaction, you had to do your INR. And so you get up and down, and patients hate it because they've got to go to the blood collection area to have their blood test, and it depends on your stability. 30% of patients, we had huge difficulty getting control regardless, so they had to come back every once a week. And if you're lucky, you could, do it once a month, which is tolerable. New drugs, really no food dietary interaction. It's really interesting. Rivaroxaban. It's very difficult to overdose because there's a maximum absorption effect at 50 milligrams, right? The treatment dose is 20. If you want to kill yourself and give more than 50, there's a ceiling effect. Okay, don't use rivaroxaban if you're an unhappy soul. Very little drug interaction except with HIV and antifungus. Just a comment about additional intervention, because it's curious to me that even in the hospital, when you're working when you're interacting with ICU and intervention, they are very gung-ho. And I'm not, so because I've just seen too many bleeding from thrombolytic therapy. So to me, if you have a PE, the really only true time when you give someone thrombolysis if they are hemodynamically unstable. Okay, so poor blood pressure, less than 90 for 15 minutes. Now, I have had a colleague in the past, ICU's called him, one of our patients in the ICU with a big PE. They called him and said, this patient's got low blood pressure, we should thrombolyze. And then in the morning, we went to check on the patient. And when you look at the chart, the nurse actually charted there, patient sleeping. So we thrombolized someone because they were sleeping and their blood pressure went down. Luckily, she didn't bleed. And then if you have, in terms of thrombolysis with DVT, probably the only time that we do them is when there's really, really proximal clots in the iliac vessels, which is more prone to post-thrombotic syndrome. And we tend to do catheter-directed lysis now. And we have, at the Alpha anyway, we have a really good working relationship with the interventional radiology team. So they'll come in at any time when we ask them to. Now, the duration of treatment, okay, the figure that I really want to get in your head is 3 to 6 months. I struggle when people say it has to be 3 months. Is a single figure ever certainty? So there's a range, and you can see here whether you treat 3 to 6 months, the risk of recurrence is similar, okay? So there's a window. But if you treat, and we're talking about proximal DVT and PE here, okay? If you treat for 6 weeks, there's a higher risk of recurrence. But if you treat longer, you don't get any benefit of recurrence, okay? So for an acute episode of DVT or PE, the initial starting point is 3 to 6 months. Then we have a discussion about who should continue and who should stop. And it depends on some of these factors. Okay, and there'll be things like if you have an unprovoked event, that is, if you're sitting here and you're young and you get a PE, there's something in you, even if I find nothing in you, because you've done the study, the risk of recurrence is high. So you should be on long term. If you have recurrent DVT, that's what prior mean. Proximal or PE have a higher risk of recurrence than just distal. If you have persisting risk factors, we talk about cancer and antiphospholipid syndrome. And if you have those other, very aggressive deficiency in natural anticoagulant, and then there's the risk. Now, the thing I just want to point out, one of my pet thing over the years is this factor V Leiden mutation. Incredibly common in the Caucasian population, 6 to 5% prevalence, okay? It doesn't occur in the Asian population historically unless there's been interracial marriages. There's a mutation called factor V Leiden in Hong Kong. It actually doesn't do anything. Okay, it was just discovered in Hong Kong. But it's not a strong risk factors for recurrent thrombosis. So that alone, that would be a good exam question. Is this predictive recurrence? The answer is no. Okay. But the problem with doing genetic testing in this day and age is once you've found it, there's some association that will be weak, and you want to take out insurance. Once it's been identified in you, you're going to have a problem. Okay, so a lot of time I get asked a second, third, and fourth opinion, and the patient comes in, oh, doc, I can't get insurance because I've had this done, I've got this, and it probably didn't mean a lot to them. Okay. So that's just my thing. If they really want to know, tell them to go and get their insurance first, then come back and have the conversation. Use of figures for the patient here. If you've got an episode of DVTP that was in the setting of major surgery, major trauma, the risk of recurrence is really low. So after 3 months, stop, okay? And then it's probably not your level, but then there's the rest, okay? And the rest, if you follow my dichotomy thinking, the rest is if you've got unprovoked events, you've got really strong persisting risk factors, and you just continue. And there's a group in the middle. We call it equipoise, okay? All right, so meaning that they have an increased risk, but is it high enough? So that's why they come in and they have a discussion, and they have to have an informed discussion, and you take into consideration the patient preference, okay? In the past, I've had, you know, various high-profile people, and there was one individual I remember. He's a professor of physiotherapy. This is back in the day of warfarin. He came into me, and I went through all the pros and cons. And at the end of it, he said, "Huyen, I ain't never stopping my warfarin because I don't want another PE, full stop." Okay, so you can tell them all the information, but then they'll make their own mind up what they want to do. So I think this is a useful one. It's really summarizing what I've just said to you. An acute episode DVT and PE, treat for 3 to 6 months. And then if they're high risk for recurrence in the EG there, then you continue. If not, then you stop if it's surgical or major trauma. And then there's a little group here in the middle where they really probably should seek specialists, know people to give them the right information, and not off the handcuff answer, yes, stop, or don't stop. Because when you're on anticoagulant, although the new drugs are very good, there is still a risk of major bleeding of about 0.5 to 1% per year. And when I say major bleeding, it means you have to come into hospital for fixing, get a blood transfusion, go to surgery, or it's involved an important organ. Okay, so it's very significant. Okay. There you go. And over the years, we've worked on various prediction models, who can stop, who can stay, but I'm not going to bore you today in the interest of time. So, to conclude, what I want you to do, if a patient turns up to ED, or even if they're in hospital and they have suspected symptom, you should take a systematic approach. Do the prediction score, but if they're an inpatient, bear in mind all those scores that we talked about has been validated in the outpatient, okay? So meaning that you're well and you turn up to the ED for assessment. If you're inpatient, I said to you, they're already at risk, so they need to have probably more aggressive investigation. Do the prediction score. If it's negative or it's low risk, do the D-dimer. If it's negative, then you can send them home. If it's high risk, go get a scan. If it's low, non-high, and the D-dimer is positive, they need a scan. Okay. Obviously, in the olden days, we used to treat these with low molecular weight heparin and warfarin, but now these days, really, we're all using the DOAC. Okay, and it makes life a lot easier. I'm finishing there, Victor, and I think in our communication, you said to me, any advices that I should give to you guys? Obviously, you're all here because you're smart people. You think you want to do medicine, I hope. But I think longevity, you need to have a hobby. You need to have something outside of medicine. And for me, it's my bike. Okay? When the hospital is giving me grief, when I can't get things done, when research is troublesome, you need to disappear for a while and you come back. So I've seen it again and again over many generations. I've had advanced training, who've had mental health issues, and it'll be here for the future. And I think the common stay in all of us is that we need to have a hobby outside of medicine, because medicine, it's all time consuming. Okay, if you all want to be a specialist, you're going to finish your medical degree, you're going to do your internship, you're going to do 3 years of residency, okay? Then you're going to have to sit that specialist physician exam, whether it's you know, internal medicine, whether it's ONG, whether it's anesthetic, whether it's surgery, and then you have to get on the program, okay? And then after that, it's a 4-year program, essentially, really. And if you want a public institution, you're not getting in without a higher degree, without a further fellowship, essentially, these days, okay? So you need a hobby to keep yourself sane in the interim, and you're going to have your partner, and you need to keep them sane as well. Okay? So that's my pep talk on the side. So thanks for coming. I'm passionate about venous thrombotic disease because it's ubiquitous and it's a real problem, and every year I have to deal with the coroners about missed events in PE and death in hospital. Okay, and the problem for you guys when you finish as intern and resident is that you make the decision in most surgical units about who gets, and that's wrong. The approach I've taken at the Alfred is I've gone right from the top. We've got agreement from all the surgical and unit heads, and this is what we are going to do, and all you do is activate the program. Okay, you don't make the actual decision because that's not really your role. Okay, and it's so important. Once you've had a death in hospital under your care, it will affect you. Okay, so you don't want to be a part of that. You want to do the right thing and be responsible. Okay, I'm happy to take any questions, or we can run away. Thanks for the invitation again. Thank you. Oh, excellent. Dinner tonight.
Thanks again, Dr. Tran, for that very insightful talk. We have about 5 minutes for questions, if anyone has any. Yep.
Pretty much, warfarin's the mainstay still. It's just that we've never done the clinical trial specifically to evaluate the efficacy and safety of the DOAC in that disease specifically, but there's no reason why it wouldn't work. And in fact, the data for cerebral sinus thrombosis or warfarin, it was also observational. So people started to use it and it was shown to be effective. Have I used it in my patients? Some of them, yes. Have they done well on it? Yes. Have they had recurrences? Not really. Okay. So there's a criteria. So ventilation perfusion, meaning that you inhale some radioactive material and then you inject the other and you match them up. So if there's a perfusion defect, so where there's a part of the lung that looks like it's ventilated well and there's not a perfusion, there's a perfusion mismatch, and we talk about segmental, then that's defined as a PE, okay? When you've got someone who's got asthma, emphysema, bronchiectasis, that ventilation is not clean cut, so you can't compare. And it means it's difficult to interpret, and that's the problem with the VQ scan, okay? And that's 60%. So we use it less and less. If it's in you guys, young, presumably you don't have lung disease, great test, okay? And the other limitation is it's really only available in big tertiary institutions where there's a nuclear medicine department, essentially. But CTPA is a great test, okay? Yeah. All right, so with warfarin, The most important effect of warfarin on 2, 7, 9, and 10 is the factor 2, okay, because that's thrombin. And we said before that thrombin is central to the coagulation system. Thrombin has got a half-life of about 48 to 60 hours. So you have to suppress thrombin before you have a true antithrombotic effect, okay? And it's going to take a minimum of 5 days, okay? All right? Now, let's just say that you get to day 5 and your INR is 1.6. Doesn't mean that you stop the enoxaparin or the heparin either. You need to keep it going until the INR is between 2 and 3 on 2 consecutive days. Then you can stop the heparin. Okay, is that clear? But a minimum of 5 days of, okay. Yeah. Absolutely, that's why you need coverage. Because if you give warfarin alone, you can tip the patient to a pro-thrombotic state. Any other questions?
I had a quick question myself. So we heard that there was some new factor 10A inhibitor reversal agents that have recently been approved. Are they
America?
Okay, so they're not in use here in Australia. No. Okay.
Yeah, it's Indexinet. I think I'm pretty sure that's what you're talking about.
Yeah.
There's a few challenges with Indexinet. It works for all, but you need to know more specifically which anti-10A drug the patient is on, because they have different volume of distribution, and how much you give is also affected by the timing relative to the last dose, okay? It's not always easy because the patient may have fallen, kind of hit their head, no family around, you have no idea when the last dose was, okay? Whereas with the Bigatran, the antidote, gericizumab, they've done it really well. It's a humanized antibody. It comes in 2 vials. You just whack it in the story. Okay. And the Indexanet, the cost of that at the moment they're asking more is exorbitant. So it's really, we're talking about thousands. Yeah, they did explore it with us about bringing it in, but I think cost would be an issue as well. Yeah, and also, you know, I think you need to frame it in the context that these are overall actually very safe drug, and because they've got such a short half-life, the probability of us using it is probably going to be pretty low. Okay. Yeah. So. Yeah. Drug interaction. So the protease, they're CYP dependent as well, so you can elevate the drug level and increase the risk of bleeding. Yeah. And the opposite is, for example, rifampicin, it induces, so you drop the drug level.
All right. Could you guys please join me in thanking Dr. Tran again?
Thanks, guys. Thanks for hanging around. I'll grab the
So guys, we're just going to break for 5 to 10 minutes. There's some pizza outside, which Connor might bring in. So have some food, have a mingle, and the next session is our AGM. So yeah, thanks guys.
Did you say AGM?
Yes, yes. We're obliged to
yeah. Oh,
AGM.
right.
Yeah.
Thanks very much.
Thank you so much.
All the best.
Thanks.